Good morning, respected teachers, friends. Thanks, BOS, for giving me this opportunity. I'm going to talk to you about how to get it right the second time. Failed fixation leads to non-union, and as we know that treating a non-union is always a challenge. So you have to find out why the first surgery has failed. Otherwise, the second surgery can fail as well. You have to find out the etiological factors. They can be patient-related, injury-related, and surgeon-related. The first two are not under our control. So let's concentrate on the surgeon-related factors. And I prefer to analyze them on the CAS principle. That is the contact of the fragments, alignment, stability, and stimulation or the bone formation. No implant is immune to failure if the CAS principles are not followed. This is a good old SP pin plate, and you can see that the nail plate junction has started failing because there is no contact, there is no alignment, and you cannot expect union. So this had to be revised, and DHS was done. And through the original track of the SP pin, we have to pass a fibula to get the union. This is another case, 8-year-old child had a fall from height, and this was a basicervical type of fracture. This was the fixation done. I'm sorry for the poor quality X-ray, but this was which came from outside, so I don't have any control. This was how the fracture was fixed. This is at the end of 2 months. The patient went to another surgeon. He saw it and he suggested revision, but then the patient refused. Landed up with me after this, and then we analyzed there was no contact, there was no alignment, no stability. So we had to revise, do a pediatric DHS. Luckily, even at the end of 2 months on fracture table, we could get correction of the deformity, and I could do a DHS, and this is a 1-year follow-up. Because the first screws were passed through the trochanteric physis, you can see that there is a premature fusion, but luckily the fracture is united very well, and this is the function at the end of 1 year. Another case, the 19-year male, Powell's type 3 fracture. This was fixed with multiple CC screws. And you can see in the lateral view, there is a gap on the posterior side. At the end of 5 months, the patient had persistence of pain. You can see absorption of neck. So there was no stability. There was absence of cambium layer, so there was no stimulation, and this started failing. So we had to revise it, and the revision was done with a DHS with a valgus osteotomy, and we could get the fracture site from vertical to horizontal. And at the end of 5 months, you can see that the osteotomy as well as the fracture has started uniting. This was a function at the end of 5 months, and at the end of 10 months, excellent union. Another high velocity injury, 43-year male, substroke fracture with comminution. The first surgeon did fixation like this. You can see that at the end of 2 months, the screw has started penetrating the hip, and the distal locking screws have started loosening out. The purpose of that so-called tension band also is really doubtful. The reasons for failure are again no contact, no alignment, no stability, and you can't expect healing. The surgeon decided to revise, and he revised at the end of 3 months in this kind of a manner. You can see that it's a day 1 failure, and the patient came to me 6 weeks after the second surgery. You can see that again there was no contact, no alignment. So we had to revise, and a DHS was done. I kept the same screw which was used for DCS. I just put it in valgus, put a DHS plate and bone grafts, and at the end of 3 years, this is an excellent healing, and this is an excellent function. Another 45-year male, comminuted intertroche plus subtroche fracture, which was fixed with a PFN, a case which was shown by Shiva right now. The nail passed through the fracture site, and you can see that there was no contact, no alignment, no stability. So this was bound to fail, but the surgeon decided to continue with the same fixation. And at the end of 8 months, this is what happened, that the nail broke, and the patient came to me at this stage. So we had to revise, put the fragment into valgus. The first track of the screw, we had to put bone grafts to block that particular track, and additional bone grafts at the fracture site. And at the end of 3 months, the fracture started showing signs of union. You can see a bone graft in the first track of the screw superior to the DHS screw. At the end of 2 years, you can see an excellent union. And I just asked him to come down, so he sent his pictures, which is at the end of 8 years, to show the function. Another 47-year male, comminuted IT with subtroche. This was fixed with a DHS, and you can see a gap superior to the nail in the neck. So there was no contact, no stability. Had to be revised because the implant broke, and this was revised. I kept the same screw, put a longer plate to take care of the stress risers because of the first plate, and put a bone graft superior to the implant so that the gap in the neck could be healed. And there was a bone graft put at the fracture site. This is a 3 years follow-up, and this is a function. Another 21-year male, intertroche fracture. This was fixed outside by DHS, and you can see in the lateral X-ray the nail has, the screw is completely posteriorly out of the neck. Plus the unfortunate story was that he had infection. So the reasons for failure were the no contact, no stability, no alignment, plus there was an infection. So after doing culture and starting with specific antibiotics, the wound was debrided, implant was removed, the patient was put on skeletal traction. 3 weeks later, after the infection was controlled, was fixed with PFN and bone substitutes. Unfortunately, there was some reactivation of infection, but the fracture healed well. This is at the end of 1 month, this is at the end of 2 years. The fracture united well, I removed the implants, and this is a long-term 9 years follow-up. The patient came just last week after I called him, and this is his function. So friends, remember the failures can occur with any implant if the principle of fixations are not followed. The take-home message is evaluate the failures on the basis of CAS principle, determine the cause of failure and rectify it. You have to do a thorough preoperative planning, keep the plan B ready, and develop a team to do simultaneous bone graft if it is going to be required. Thank you very much.